Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Thank you, Debbie. I'm so excited to have you all with us today. We're going to be talking about Rural Health Transformation Program. This session was organized and will be moderated by Craig Schneider. And for those of you who are expecting federal officials, I'm sorry to disappoint you, but given the whole nature of what's going on in Washington, the ones who are committed and the ones that we had invited were not able to be here, but that's okay because we've got some fabulous panelists with us today that are going to be talking about rural health transformation. So let me go ahead and bring Craig to the screen. Craig, it's good to have you with us.
Thanks very much, Norm.
And then you've got some slides that you want to walk people through, so I will go ahead and run those for you from my panel, if that's okay, and we'll go ahead and get started with that.
Sure. Right, so we were thinking, if there's no federal government working right now, what would be a good topic to address? And we decided that the Rural Health Transformation Program would be a great topic for the NAHDO membership and other interested stakeholders. So we're going to spend the next hour thinking about this Rural Health Transformation Program and how it relates to health data organizations. And we can go on to our next slide to meet our panelists. So we're really pleased to have two nationally recognized experts on this topic. Jolie Sonier, Senior Fellow from Mathematica, and Greg Uszak, an Associate Principal at my organization, Health Management Associates. And I am a Principal at HMA and have been involved with NAHDO for approaching 20 years, so delighted to be here today. So before we meet our panelists and get into the conversation, we thought we would do a little bit of level setting just on the Rural Health Transformation Program. And if you're not familiar with that acronym, NOFO, it's the Notice of Funding Opportunity, essentially the application, the opportunity for states to submit applications for the funding. And if you're not well versed in this, you'll find out there's a lot of funding available for this program. And then after we meet our panelists, we'll get into a discussion of data sources supporting the health data infrastructure, using health data organization data to support rural health transformation program initiatives, and then hear about some of the ideas that states have for using the funding, and maybe some of those initiatives might cross states. And then we should have some time for questions from the people who've dialed into this session. So we definitely look forward to that conversation. So let's talk about what's in the legislation. For those who don't love the official title, you can call it Public Law 119-21, which was signed on the 4th of July this year. And Section 71401 created the Rural Health Transformation Program. And if you want to look at the text of the law, which I'm sure everyone does, there's the URL to find it. It is a substantial amount of money. $50 billion over the next 5 years. That's calendar 2026 through 2030. And there are two pots of money available. So every state is eligible for $100 million. And there is an additional average of $100 million, adding up to $50 billion a year. But that funding is subject to CMS approval. States are the only eligible applicants, and each state's governor can decide on who the lead agency will be for the program. The District of Columbia and the territories are not eligible for this money. And just a terminology clarification, I'm calling these pots. It's an easier term to think about, easier to write on a PowerPoint slide. In the legislation, they were called tranches. And just to make it a little more confusing, CMS is not using the term tranches. CMS calls the first pot, that's the everyone gets $100 million. They call that, quote, baseline funding. And then the second pot, they call workload funding. And also I want to note that whatever states get this year, future awards are subject to CMS review and approval. So just because a state is awarded money in 2026 does not mean that it's guaranteed for the subsequent 4 years. And so the strategic goals of this program are to make rural America healthy again. I'll leave it up to you to agree as to whether again is an appropriate term for that. Another goal is sustainable access to care, workforce development, innovations in care, and innovations in technology. So the timeline for this application process is pretty condensed. CMS issued that notice of funding opportunity in late September, and states had until November 5th. Oh, wait, that's tomorrow. Are you kidding me? To submit their applications. Why is this timeline so darn condensed? It's because the statute says that CMS must make the awards by December 31st of this year. And those of us who were reviewing legislation over the summer thought, well, you know, states will have till December 1st, Thanksgiving. But CMS felt it needed more time to review these applications. So that squeezed the deadline back to early November. So many of your colleagues at state agencies are probably scrambling to polish up their applications as we speak. So what is CMS going to be looking at? So there are two main categories of scoring for the NOFO: rural facility and population score factors. Those are things like the percent of rural population, the number of facilities serving rural patients, and the size of the state in square miles. And then the other category is technical score factors. And that's a little more subjective. Things like the initiatives that the state is writing to address population health, its partnerships, its data infrastructure approach. If you want to do a deep dive in this, the NOFO has about 35 pages of detail in the appendix on how the scoring works, but I will spare you those details now. Okay, so what is the funding intended to be used for? Things like prevention and chronic disease, workforce, behavioral health is appropriate. There are a couple of other additional uses, but they may be subject to restrictions, things like capital expenditures and infrastructure and fostering collaboration. And so before we hear the panelists' reactions to all this and we get to meet our esteemed panelists, what do the states have to submit? Well, the simple thing is just a summary of their application in one page, but then it's a pretty substantial application. A project narrative of about 60 pages, a budget narrative of about 20 pages, and several forms to complete, and states so inclined may submit up to 35 pages of additional material. So that's an incredible amount of writing and proposing and thinking to come up in this pretty condensed 6 or so week time frames. Many states put out requests for information to get great ideas from the public and their stakeholders. And we wish them all the best of luck in getting the maximal amount funding. So let's meet our panelists and get their thoughts right now. And so, Norm, are you bringing Julie and Greg on screen? There they are. So why don't we start off with Julie, and then we'll meet Greg.
Sure. Hi, everyone. Happy to see you this afternoon and to talk about this very important topic. I'm Jolie Sonier. I'm a senior fellow at Mathematica. And I have spent, I would say, pretty much my entire career right at the intersection of data and policy as it relates to healthcare. And so talking about the Rural Health Transformation Program is kind of my happy place, because the policy parts of it are incredibly important and the data parts of it are incredibly important. So just as background, I'm located in St. Paul, Minnesota, have spent much of my career. So I've worked for the state of Minnesota in various capacities. One of those capacities was as the state health economist, where I helped to work on collecting a whole variety of different sources of data, including setting up the all-payer claims database about a little over 15 years ago. But a couple of other roles are also, I think, really relevant to this conversation. One of them is that I also worked for several years for the State Health Access Data Assistance Center, or SHADAC, as it's affectionately known, at the University of Minnesota. And basically what we did there was we helped states think about data sources to inform health policy. And so I got the chance to work with states all across the country on exactly these kinds of questions. And it was right at the time when the Affordable Care Act was being implemented. And this current situation really feels to me similar to that, in the sense of the need to ask questions about, like, how are we going to know what the impacts of these major policy changes are, both the intended and unintended impacts? What are the sources of information that we have to answer those questions? What are the gaps in those information? How can we fill those gaps? How can we combine information from various sources? So it really feels kind of familiar, like a familiar place that we are. A couple of other things that I've done in my past that I think are also that inform my perspective. One is that I, for a few years, was the director of the state of Minnesota's employee insurance program. So we were purchasing healthcare on behalf of our state employee population. And in the state employee groups, you have got to have provider networks in every single corner of the state. Minnesota is a pretty large state. And so just this sort of need for geographic dispersion, understanding the providers and making sure that you have provider availability is very important. And then the other function that I've played, I also ran a nonprofit called Minnesota Community Measurement, which collected data and measured healthcare quality and cost, again, in every single corner of the state. And one of the things that I really treasured about that time was the ability to interact with providers, and especially the rural providers, who often, I think, have very innovative and, like, by necessity, creative approaches to dealing with some common problems. And so bring that kind of familiarity about that perspective as well to this conversation.
Great. Thanks so much. Greg?
Thank you, Craig. And everyone, it's really nice to meet you. My name is Greg Uszak, and I'm an associate principal with HMA in our Chicago office. I've been working with Craig for several years here. But my background is in that provider side finance. I've got more than a decade of experience in both public accounting, working in a large integrated health system of about 17 hospitals, with a substantial amount of those hospitals in a rural area. And then at HMA, I've continued that practice, working directly with providers in terms of service line, financial planning, and analysis. And I also specialize in that Medicaid space as well too, and support about 25 hospital associations throughout the country in terms of their Medicaid reimbursement, their provider tax programs, and have done a tremendous amount of work with rural critical access hospitals through that space. And so kind of where I'm plugging into this rural health dynamic as well too, is kind of taking that macro and making it micro. You're looking at a lot of these, the rural health challenges from and the opportunities from that state and regional perspective. And how do you take that and apply it and kind of integrate it into a local system to make sure the rubber's meeting the road? So over the last the scramble of the last 6 weeks, since the point the NOPA was released to the point the application is due tomorrow, supported clients in about 7 or 8 states supporting their application development, and now kind of gearing up for once CMS makes these allotment decisions by the end of the year, as they're required to make the decisions by 12/31/25. CMS is also they've been pretty forceful in that they want the funding to go out to the providers and the vendors very quickly. They're expecting funds to go out between the first and the second quarter of 2026. So we are trying to help them implement these strategies tactically very quickly. So looking forward to talking about what we've done so far and what we're hoping to do going forward here.
Great, thanks. And Greg made a good point that probably is worthy of clarification. So the NOFO is being reviewed by the Centers for Medicare and Medicaid Services, which is actually somewhat strange. My speculation is, well, that's where the bodies are. They have enough people to throw at this, and to me, it would seem more natural that perhaps the Health Resources and Services Administration might be actually doing the reviewing. But for whatever reason, Congress in its wisdom gave the assignment to CMS. But it's really important to emphasize that this program is broader than just Medicaid. And something Julie said that I think is a great segue to our first discussion topic is about the data sources, right? So I'll start off our panel conversation by asking what data sources would be helpful to states in responding to the notice of funding opportunity.
So thanks, Craig. I'll get us started with that. I think when I thought about this question, I thought about it in really 3 different ways. So like number one, there are specific kinds of things that CMS wants to see in state applications. So things like rural demographics, health outcomes, healthcare access in rural areas in your state, rural facility financial health. So there are some very specific things that CMS wants to see from states. So we'll talk about that a little bit more, but I think also thinking about the data just in terms of, you had that slide that showed what are the allowable uses of the funds. And I can't remember if you mentioned or not that states have to pick like at least 3 of those allowable uses of the funds. And depending on what priority areas the states choose, I think the data sources that kind of support that are going to be a little bit different. But hopefully there's data available to actually help states say, like, of these areas that we need to choose from, which ones does the data show are the greatest areas of opportunity for us? So there's the application, like what has to be in the application. I think there's a second consideration here, like when states are putting together their applications and recognizing that probably a large part of this audience that's here with us today, like wasn't necessarily part of those applications, or hopefully those folks, if the applications are finished, those folks are just, taking a well-deserved nap. But how are we going to use data, or how will states use data to support operations and implementation, and how will they describe that in their applications? And then there's a whole evaluation section. So in terms of the application, like I said, thinking about how do we use data that we have in our state to select the priorities that we're going to focus on for this program. So knowing things like the system characteristics. So how many providers, where are they? How many patients are they serving? What services are available and in which places? Where do we think there are shortages of services? How are the providers doing financially? What's the payer mix? What is the variation in uncompensated care burden across the state? So there are data sources for all of those sorts of things. And those exist to varying degrees across states. So there are some data sources that are available uniformly across states, and there are some that are very state specific. So all payer claims databases are a good example of about half the states have those. And a data source like the Behavioral Risk Factor Surveillance Survey is one that is available across all 50 states, very commonly used to answer questions like, what's the prevalence of the diabetes population in our state? So it really depends on the priorities that the state sets. As far as, sort of the data sources in the application itself, like I said, CMS wants to see things like rural demographics. Most likely that's going to come from census data. Perhaps the state has dedicated resources. I know in Minnesota, there's a dedicated state demographer that could be an additional source of that information, especially population projections. Health outcomes. I think this is a place where all payer claims databases, those surveys like the Behavioral Risk Factor Survey, if the state doesn't have an all payer claims database, is going to come really handy. Sometimes vital statistics for things like mortality or low birth weight, and perhaps HEDIS measures from health plans. So maybe for the Medicaid population, perhaps more broadly for the commercial population, depending again on kind of what the state's regulatory regime is and the data that they're already collecting from health plans that do business in the state. CMS is looking for information on healthcare access. So things like the average distance to care, the availability of providers, transportation. Some of those things, especially the distance and the availability of providers, are great things to answer with data sources like all payer claims databases and hospital discharge data, to the extent that those data sources are available in the state. And then perhaps household surveys. There's, again, significant subset of states that conduct their own household surveys about insurance coverage and sometimes include questions about things like transportation as a barrier to care. So those are just some of the examples of data sources that can go into the actual application. A couple of things to think about there, sort of this distinction between, or the unit of analysis. So for some questions, it's important to think about where people live. And for some questions, it's important to think about where they get care and being clear on when each question is appropriate. But a data source like an APCD or a hospital discharge database can give you the answers to both of those types of questions. One of the things that I think is really important is, the application has to have a section about metrics and evaluation. So the state has to say, for each initiative that the state is proposing, there has to be at least 4 quantifiable metrics, and at least one of those has to have a county or community level of detail. So I think 2 things about that. One is that timeliness of data is going to be very important. So if we are relying on data sources that have a lag of 2 or 3 years of data availability, that's probably going to be problematic from CMS's perspective, because they're going to expect reporting on those metrics, and it's going to be important for like the second, third, fourth, fifth years of funding in this program. And then granularity is really important. There are many data sources out there that don't really allow very well to get down to that local level. One that's very common is that Behavioral Risk Factor Surveillance Survey for things like diabetes prevalence by county. The way that that is usually calculated is by combining like up to 5 years of data to sort of get enough sample size to calculate that at the county level. And that's something that I really think is going to be problematic, perhaps, for states. So like if you get the new year of data, if you're combining it with 4 old years of data, it's going to be very, very difficult to see the impacts of the program initiative. And so that's, again, a place where I think that an all-payer claims database, hospital discharge database is going to have an advantage, perhaps not in terms of timeliness, kind of depends on the state, but for sure that has that sort of extra ability to get down to the local level. There are gaps in those data sets that we can talk about later, but those are some of my initial thoughts on how data sources can inform the application.
Great, thanks so much. Craig, is there anything you want to add or expand on?
Yeah, and I think Julie covered it very, very well. And I think, kind of going back to what I've seen over the last couple of weeks as folks have been, using a smattering of information sources to inform their application. And if they haven't already utilized data to, put together a robust application, they're going to be required to, in the next couple of months here as well too. But I think that what I've seen so far, the two kind of prevailing questions that I've seen, because there's a wide degree of variability in terms of how states have been, approaching their strategy development for rural health, and then also writing and speaking to their subsequent application for funding. But kind of the two questions that have been very critical have been, where are rural patients choosing to seek their care? And then what are the gaps in rural care by county, by community, and things like that? So again, Julie kind of mentioned, and it's been a critical component, but mapping the gaps in access through analyzing the provider and facility distribution of services. What are the driving distances to the major services for specialty services? And then identify which services are being accessed by rural patients and which ones are being, in urban environments. So how many rural patients are driving to the big city for their care? How can care pathways be modified to be able to help, plug this gap? And the data, to date, as Julie mentioned, a claims database to kind of map the service utilization by these populations, looking at the health needs, that chronic disease space as well too. Folks have also been using, national highway network data, rural or urban definitional data from the National Center for Health Statistics, and then a lot of information on from the U.S. decennial census, which has also been challenging because the census website is not fully functional during the government shutdown. So a lot of folks pulled data in August, and they were very happy they did. Some folks that waited in the first week of October, they had some challenges. They had to find some patchwork sources to be able to pull that information and just really hope that it was great, or that it was usable data. So, and then as mentioned as well too, kind of cross-referencing some of this, the patient level data with other goals of the program, which is the financial sustainability of these providers in these areas. That's going to be requiring, the Medicare cost report, audited financial statements. I think the other part too that's been challenging with some of this information is how do you create a governance structure to be able to utilize this data going forward? I was supporting one hospital association, and I can tell you finding a consensus amongst a group of AD CEOs is challenging. So getting the data, validating that it's good data, and then also making sure that you can kind of come up with a framework that can be utilized by everybody in the health ecosystem in that space is also, it's been a challenge so far, and it's going to be, there's no clear-cut answer at this point in time. So, having access to all this information and being able to utilize it for a common good is going to be interesting to see how states, approach that dynamic.
Great. So, our first question is, how would the data sources help fill out the application? Now we're going to flip that frame and think about how states could actually use the Rural Health Transformation Program funding to support their health data infrastructure, because the NAHDO membership knows well that these are, essential resources that are woefully underfunded. So how might this program actually support these kind of health data organization resources?
I think, there's the notebook puts a lot of emphasis on kind of that population health management. And it's looking at existing infrastructure, and it's looking at plans to bolster the population health framework. And I think what we've seen so far in terms of how folks have been approaching this, there seems to be a couple. As I've been working from state to state, there have been some specific services that I've seen surface. Rural access to primary care and hospitals is always going to be probably one of the number one problems in most states, or one of the challenges. So, I would say a lot of the focus in terms of building out the infrastructure and shared infrastructure amongst providers, and particularly in that, critical access or rural space, and how that intersects with the primary care doctors, FQHC, behavioral health, and then chronic care providers in those networks. they're looking at means of a lot of states have a jump start on that, and they're looking at funding to be able to support existing initiatives or create a new infrastructure going forward. In addition to that, what I've seen a lot of focus on in terms of building up the infrastructure to support some select service lines. There's been a strong emphasis on maternal health and OB services. As everyone knows, that's been probably a critical challenge in pretty much every state. Access to labor and delivery services and making sure that mom and dad don't have to take off a full day of work to even get their prenatal care, just to drive to a hospital to get their check-ins and their ultrasounds. Behavioral health is also another area too, where a lot of folks are trying to work on, say, even like health information exchanges, being able to build on modules and frameworks to be able to share that, create that infrastructure if it's not there, and then again, make it a shareable platform amongst all the different stakeholders in that particular region or market. Cardiology, urology, ED service infrastructure has also been a focus for a lot of this particular type of funding, as well as oncology services. I think oncology and maternal health have probably been the two strongest areas where I see folks probably taking steps to improve their infrastructure or evaluate their existing infrastructure, and they're hoping to kind of add to it and build upon what they've got in place to be able to kind of support those going forward, because those will be addressing a well-known and documented health need. And then also too, I would say that the one area too where I'm seeing folks where there's a lot of desire, but they're still trying to navigate their strategy is really that chronic disease management state. There's a lot of focus out there. There's a lot of new vendors and providers entering that space. It would probably bode well. It bodes well too to speak to technology advances, AI, the emphasis on consumer-driven technologies that's very clearly stated in the NOFO. How can somebody log into their phone and get a very quick appointment when they're talking about some challenge related to their diabetes? Those are probably the areas where I see there's probably the most excitement, but there's also not necessarily a definitive game plan at this point in time. So again, getting as much information to kind of support a strategy, a statewide strategy, and then the adoption and integration of that amongst everyone is going to be an area to keep under evaluation going forward as well too.
Great, thanks so much. Jolie, do you have some additional thoughts on this question?
I do. So, one of the ways that I think about this question is about, what data is needed, like when and by whom. So there are a lot of kinds of things that states are going to want to be doing through the Rural Health Transformation Program that require like very timely data, sometimes real time. So things like, some of the like really good connectedness to health information exchange for things like admissions, discharges, transfers. Remote patient monitoring is another like key application that I would expect to see expand to a significant degree as a result of this program. And hopefully like general interoperability at the point of care, so providers can see like what tests have already been done for this patient and like what things have we already tried, what comorbidities does this person have, hopefully leading to better overall management of chronic disease. I think of it in a few buckets. So like how states could support their health data infrastructure. So one of those is to enhance their existing data sources. And I kind of call this like traditional analytics. So it is things like the state's APCDs and discharge databases. So things like linking APCDs to other data sources, like vital records, for example. Things like working on improving the timeliness, perhaps the public reporting and transparency of data from those sources, I think is a big opportunity. And then thirdly, I think there's an opportunity here to develop methods to address gaps in the data. So we know there's a big gap in APCDs as far as self-insured employers go. We talk about that one a lot. We don't talk about the uninsured very often, but the care that uninsured people are getting is not showing up in APCDs. And depending on the question, I think there's a lot of different approaches to modeling to address gaps in those data. I think it's absolutely possible. It has to be sensitive to the question. So, for example, for like a rural health transformation use case, how important is it to like know exactly which hospital somebody went to? Sometimes that's very important. versus like in aggregate, what does the population that lives in this area need in the future for care? Another consideration that I think is really important is, as far as data gaps, is for us to be thinking about the degree to which some of the new technologies, sort of the new kind of like direct to consumer, I would call them, ways of delivering care might be fragmenting care, and as a result, fragmenting the data. So like telehealth in particular, if there's a carve out that's, where like an employer is just, offering their employees an ability to connect to a different platform, and it's not really a health insurance claim, then that would be something to think about as a gap in the data, or other carved out benefits like prescription drugs, for example. So that's one bucket, the traditional analytics bucket. The second one, I think, is there's potential new data sources. So we've heard already today quite a bit about the desire to gather clinical data, sometimes to link it to APCDs and sometimes not. I think of this as most valuable, not like to have the universe of electronic health record data available, but to think about ways of extracting systematically key data points, things like blood pressures, results of hemoglobin A1C tests, things that are basically like key quality markers that would be useful to have alongside of quality measures that can be calculated from an APCD. And there may be ways for states to leverage an existing health information structure for that. Community information exchange. So Greg was talking about sort of the needs to build better infrastructures like related to behavioral health and like OBGYN and other sources of care. One thing that we know is a priority in some places is a better infrastructure that connects up providers that address health-related social needs with clinical providers. And I feel like that whole area is still very much in development. And then my last point is kind of a pet issue for me, which is to think about data that can address pain points that I think are really significant barriers to progress in value-based payment. So at the state level, we really would like for value-based payment reform initiatives to be multi-payer in nature. And one of the lessons that I learned from some of my past work in Minnesota is that payers are, they're sending lots of data reports to providers, and providers are receiving them, and sometimes they're in PDFs, but there's not enough commonality across those, and providers really, really wish for timely information that is also consistent across those sources of information so that they can focus on improvement. So that would be something that I would say is an opportunity for states to develop using the rural health transformation, especially for states that are going to be focused on payment reform as a key element of their program, addressing some of those pain points, perhaps by just playing a role as kind of setting core standards for those data flows between providers and payers as it relates to value-based care.
Great. Yeah. And, we've talked a lot about how these data sources could support the NOFO applications, but after the states hit send tomorrow, they're going to start focusing on, implementing these ideas that they scrambled to come up with. So what are some of the strengths and limitations of all payer claims database data and hospital discharge data to help states actually implement the initiatives that they said to CMS? This is a great way to use your $100 million.
Yeah, so let's start with the strengths. One strength that I think is that we don't sort of pat ourselves on the back enough about is that health data organizations are usually one of the most trusted source of information, right? So it is objective, it's fact-based, there is no political agenda, and that can be a very significant advantage. It's also a source of baseline data for a very wide range of indicators, some of which you can't find elsewhere. So use of services, geographic variation in utilization and cost, patients' travel patterns, and many claims-based quality indicators. So those are all like really strong points in favor of APCD and hospital discharge data. And again, as I mentioned before, some of that like really much stronger ability to do very localized analysis than many other data sources. I think in terms of limitations, for many people that are like part of the audience here, this isn't going to come as a surprise. It's either scope or completeness. So for hospital discharge databases, we've got a subset of services, right? So ideally, we would, when we know that someone was hospitalized or had an ER visit, we would like to be able to see what happened upstream that could have possibly prevented that. And you can't do that with a hospital discharge database. You can do it with an all-payer claims database, but again, you've got these gaps in terms of the population that's covered. So pros and cons of both. Another issue to think about is border crossing. So where people go for care is an issue, and it can be very significant. So one time when I was working for the state of Minnesota, we did a study that basically looked at where people were going for hospital care. And Minnesota is a really big state, and like some parts are very, very rural. And it turned out that for the entire western half of the state, 25% of the time when people are hospitalized, they're going to North or South Dakota. And so like if we didn't have data, and I think for that particular project, we had gotten data from the North and South Dakota Hospital Association to be able to enable us to be able to do that sort of analysis. So thinking about care that crosses state boundaries is going to be really important. And then timeliness is an issue. So it's very important, especially if we're talking about initiatives like payment reform, where there's going to be money at stake for providers. When I worked at Minnesota Community Measurement, came on the scene, there wasn't really a lot of value-based contracting going on. So we had been doing this activity around quality measurement and transparency for a number of years. But what we heard from providers was like, if people want us to like have money on the table in terms of these quality outcomes, it is not good enough for us to be able to get those quality measure results just once a year. So we needed to really think differently about how we collected data and fed things back to people in more real time so that they could act on it.
Right. Greg, would you like to chime in on that question?
Yeah, Julie covered it very well. And again, I think I think the other part to consider though is in terms of, like I said, my intersection is making the macro micro. All this is really good information, and I think the areas too, as I'm kind of working with providers directly, it's how do you kind of use this to reforecast? How do you take this information and does it have the level of granularity needed to kind of support redesign services and things like that? So again, the access to the more data sources you have to be able to cross-reference all of that, and as Julie mentioned, looking at what's happening upstream, what's happening downstream. That's the important information, because I think the other added component to this is, as you're talking to some of these groups, a lot of the times, as Julie referenced, a lot of these rural providers and the troops on the ground, they're very much ready to be creative, to work with the other folks, but sometimes getting a consensus amongst the executive teams, the leadership teams, no one really wants to give up complete control in the management of the patient, things like that. So, having as much granularity and interoperability between data to be able to kind of support these decisions, to make more informed decisions on the ground, is going to be very important, along the way here. So.
Great. So, Greg, you said in your introduction, you've been working with several states or stakeholders within the states on their NOFO applications. And I think a lot of people would be interested in hearing what are some of the initiatives that states are coming up with. So if you want to start us off with what you've heard about some of the ideas.
Very much a wide degree of variability from state to state. That's always been very interesting to see, how they're envisioning this play out. I think some folks just think that unfortunately, I think some folks just think that they're getting $100 million check in the first quarter, and how to figure it out. But other states are really taking a nuanced approach and really, again, getting to the core of what the application is requiring, and kind of transforming the care and the delivery of care for rural patients. I think the ones that like I mentioned, maternal health seems to be a strong focus for a lot of folks, and I see that's where probably a lot of the deep dive on the data. A lot of states are going to be taking kind of a hub and spoke approach to some of these specialty services, looking at the intersection of how the providers work together. In terms of making the care accessible for, say, prenatal care at a local primary care office or outpatient clinic, and then going to the the hospital for the delivery and things like that. I think seeing that specialty service, the specialty service hub and spoke model is probably a common theme amongst a lot of the applicants in terms of what they're developing there. And I think it's going to be the specialty care services is a big one. And I think the other one that I'm seeing as well too is the influx of various types of new vendors entering the market. Some of these primary care as service type companies or health pods. Can you put a kind of a mobile unit type technology with expanded diagnostics or expanded scope of services into these remote areas and increase access points for patients. Those are probably the themes that seem to be generating the most excitement across all states. Because again, no two states are alike in terms of their needs or their response to these applications. But again, some of those critical areas that there's critical mass and support is going to be in that maternal health, the oncology, and the primary care access. I think the other thing I'm going to be interested to see as well too, and I'm just kind of a little bit of a tangent here, but the one thing that the NOFO in response to the NOFO, we did see questions surface from providers saying, how can we work across state lines? Looking at some of those more really more remote areas. If you have one and say, and I'm just picking on it because Julie already mentioned it, Minnesota, looking at its neighbors. And if the nearest facility for, a patient pathway is, Wisconsin or another state, what are the opportunities to kind of, build partnerships there as well too? We saw that question come through a few times, and CMS was very much open to hearing responses to it. They said, you can factor in decisions like that. So looking about, interoperability and infrastructure across different, regions that generally don't, they have different payers, they have different commercial plans, they have different Medicaid structures. It's going to be interesting to see that as well too. But I am excited about the level of innovation that folks are trying to bring to the table here for much needed service delivery.
Great. Julie, are there any examples you'd like to share that you've been hearing about?
I would second Greg's comment about the sort of the degree of variation across states that is very evident. And I think that's kind of exciting because I think it shows that people are thinking carefully about and talking with stakeholders in their states and thinking about what's best for our state. So kind of at the end of the day, if you've seen one state, you've seen one state, because there's variation in, the healthcare landscape as it exists today, policy approaches and priorities, including political philosophies sometimes, and in the data infrastructure that supports that. Couple of things that Greg mentioned that you're seeing a lot of that he didn't talk about that I think are worth talking about. One is, there is some focus on kind of the prevention and management of chronic disease, which sort of goes, under the label, Make America Healthy Again. That seems to be a focus. In addition to the specific focus on maternal health and behavioral health in particular. We have not talked here very much today about workforce, but there's a lot of attention to figuring out what is the future, what does the pipeline look like for the future workforce that we need to support healthcare in rural areas. And then I think there is going to be significant attention to payment reform. So really thinking about, the outcomes that we're getting from our system, or how can we redesign the financial incentives for the system in order to do things like reward going upstream and preventing emergency room visits, because we all sort of know that in a fee-for-service system, if you're preventing the need for services, then you're losing money unless we've redesigned the financial incentives in some way. So hopefully we'll see a fair amount of payment reform as well.
Julie, I really like your comment on the workforce development. That's a very, very critical element to this, and it is very much under development in a lot of states. I think the thing that's been interesting is a lot of states have been trying to bolster existing programs that have not necessarily been well funded. But as you talk to a lot of these groups, one, how do they build it up, and then how do people not fight each other for the same talent? They're all trying to serve the same. But, hey, again, I've harped on maternal a lot too. There's not that many OBs in the rural area, so you need to make sure that they're serving all the patients, and we're not necessarily a food fight for who actually gets to employ that one. So that's been a very interesting dynamic. But again, I'm very glad to see the renewed sense of focus on the workforce development in these areas.
Right. And I'll add, I was just in rural New Mexico last week, and I want to make clear, this is not something necessarily that the state is putting in its application, but it was definitely a need I heard from providers in a pretty rural area of the state that we don't necessarily think about as much as hospitals and primary care and maternal care and specialty availability is transportation of services. That ground ambulance transportation is really hard to access. So patients are taking helicopters and airplanes, enormously expensive. So it would seem in that example, some investment to shore up the ground transportation network would be better for patients and save the system a lot of money. So it'll be interesting to see what kind of creative approaches the states take in their applications and that CMS rewards with its awards. So we have about 10 minutes or so for questions. I've seen a lot of great comments in the chat, but I haven't seen anything that's a specific question for the panelists. So want to give people dialing in right now the opportunity to ask anything that they might want to ask. And that question about, hey, what initiatives have you heard about? If you want to share something you've heard your state is doing, we'd love to hear that either in the chat or people putting in the Q&A or Norma, are people able to go off mute?
No, they can chat away by typing.
Okay, chat away by typing, or again, either in the chat function or the Q&A function.
And we have been putting their main comments on the screen so that others can see them. They can see them as well. But I think that it'd be great if we could get a few people to answer this last question, which is what else is going on in your states? I think people want to know. Like, we don't know everything. None of us knows what's going on everywhere, but maybe we can crowdsource that a little bit.
One thing, Craig, while we're waiting for that, one thing that came to mind for me when you were talking about the transportation issue was the potential role of, I guess what we're really saying is like EMS is really overburdened. What I'm about to say is actually going to burden them more, but sort of like the potential for we've all probably heard about like the community paramedics, where like as a tool for like managing chronic disease better in the community. So like as another potential like area of real investment or rethinking like what the role of that function is, while also like being clear about the need for like a good transportation network as well. But that's another example of a really innovative approach that is out there, and I think there's probably some good research evidence that shows that it works. But something that we may see more of under this program.
And on that note too, I thought one interesting challenge that I heard from one state as they were talking about the rural transportation was simply scheduling. They said it's hard to find drivers for these things, for a lot of these programs. And most of the drivers, and rightfully so, work more of an 8 to 4 or 9 to 5 type shift. So a lot of the times when you have these patients from a remote area, they have to be the first appointments of the day. They have to be before lunchtime because getting access to those drivers for those late afternoon appointments is not necessarily going to be viable as well too. So I thought that was interesting. It seemed to be a little bit more of a humbling challenge, was just simply the scheduling of a lot of these services.
Yeah, and that's another thing that happens when you don't have like the capacity where it needs to be, is that all of a sudden, like, if you need, if the closest specialty care services are 3 hours away, then you've tied up your ambulance for 6 hours to drive there and back. And it's very limited capacity to start with. So I think underlines the importance of being very intentional about what kinds of things need to be available, like within some, relatively short distance, versus what kinds of, sort of an approach that thinks about what's the impact of distance for these types of services, and making sure that it's available within a reasonable distance for people.
I personally would love to see the expansion of, say, some of the rideshare apps. Again, folks are familiar with Lyft and Uber and these types of services. Again, it's a consumer-facing technology that a lot of folks are familiar with. Sometimes, though, in some of these counties, you might only have 1 or 2 Uber drivers that log in that day. So it can be a challenge for consistency. So I've heard folks talk about it, and I'd love to see expansion of that type of service as well, too.
Right. And the other issue in rural communities, particularly those that are mountainous, is that a mile is not a mile, not necessarily a mile. That, on a map, it might appear to be just a few miles, but in reality, it's a half hour, 45 minutes to go through those winding mountain roads. And then, of course, during winter months, it's that much more difficult for people to get where they have to go. So these are real challenges that hopefully this program can partially address.
Well, there's no harm in ending a minute or two early if that's okay with everyone. So let's go ahead and just we do have one slide here just to memorialize this, officially thanking everyone who participated, especially our presenters today. And there is their contact information, so in case you want to reach out to them for additional information. So very, very grateful to have them with us today. And I do have a little overlay here that tells you what's next. What's next is the state showcase on data management, quality, and public accessibility. That's going to be starting at 4 p.m. Eastern, so in about 14 minutes. I just want to kind of emphasize that we've done a few things different this year. We have how-to sessions, which are more sort of explaining processes as opposed to explaining findings. It's like, how did you do this? How did you do that? We get that every question every year. People will do a presentation, and then people say, well, how did you do that? I was like, well, we need another 30 minutes to explain that. So I've done that one. But one of our big additions is the state showcase. We have 2 of them, today and tomorrow. We've invited 6 programs to come and just highlight some great thing that they are doing so that people can see what's going on in the states around the country. So you'll want to join that one. They're going to be talking about data management, data quality, and then public accessibility. That's again at 4 p.m. Eastern, so in about 13 minutes. So thank you, Craig, for putting this together and for helping us deal with the vagaries and inconsistencies of federal participation. So it's a fabulous opportunity, and thank you, everyone. We hopefully will see you at another future session.
And thanks so much to Julie and Greg for really outstanding discussion. I enjoyed the conversation. Thanks, Norm.
Thanks for having us.